first of all, let me wish a warm welcome to everyone who is joining us tonight here, tonight for us and the early afternoon for Prof. Christophe Blockeel. I'd like to obviously say thanks to Ferring for this particular webinar and getting such a distinguished speaker for a topic that I think will bring a lot of interest to all of us here. Prof. Blockeel will be speaking about improving live birth rates in IVF, the potential mechanisms of benefit of HCG-driven LH activity. We know this is a big area for debate. There are a lot of people who go one way or the other, and it'll be very interesting to hear what are the benefits of HCG-driven LH as opposed to non. Just before that, I'm going to do a few announcements and housekeepings for MSART. So as you all know, the Malaysian Society of Assisted Reproductive Technology will be having our annual Congress in 2024 at Sunway Pyramid Convention Center. It will be in just over a month's time on the 5th to 6th of October. So registration is now open. If you can move down the slide, Mira. Sorry, just a little bit about our keynote speaker first. Our keynote speaker will be Prof. Kazuhiro Kawamura, who is an expert on premature ovarian failure and one of the authorities in the region and indeed the world on ovarian activation and in vitro activation, actually. So it'll be quite an interesting keynote speech that we have prepared for you. Now, as I was saying about the registration, if you can just move down to that, the registration is already open. For all of you who are from Malaysia, you can register for the conference itself on the MSART website. You can visit msart.my or the CME clicks which are there, and you'll be redirected directly to the registration. You can also choose to email either one of the emails down there or WhatsApp the phone number of the Secretariat for more information. For those from overseas, seeing as how we have a large delegation from Thailand today, I believe some attendees are also from Vietnam and Indonesia, you can choose to attend via our hybrid option, which is only for people outside of Malaysia, and it will be through a Zoom login. That also you can register on the normal site. All right, so moving past all that, we will now get into the introduction today. Here are the rates, but again, that's available on the website, so we'll move on from that, Mira. All right, so this is today's agenda. First, I will introduce our esteemed speaker, who will then give us a talk lasting about 30 to 35 minutes. And then we hope to have a lively question and answer session, because I do believe this is an interesting topic of which there will be a lot of things you would like to ask before we close the thing, probably around 9 p.m. So without any further ado, I always forget this part. So any questions you have can be submitted to the Q&A box. If you look at the bottom of your screen, the Q&A box is right next to the chat box, and you can just submit any questions there. I will read through them and see the ones that are suitable will be put forward to Prof. Blockeel to answer. Okay, so let me tell you a little bit about Prof. Christophe Blockeel. He's the medical director of Brussels IVF, the Center for Reproductive Medicine at University Hospital Brussels in Belgium. As I said, one of the most beautiful cities in Europe. He is also a visiting professor at another beautiful city in the University of Zagreb, Croatia, at the School of Medicine in the Department of Obstetrics and Gynecology. He is a past president of the Belgian Society for Reproductive Medicine, where he served from 2017 until 2020. Prof. Blockeel graduated from the University of Ghent in Belgium in 2000 and actually became a specialist in obstetrics and gynecology in 2005. Quite a short term, actually. If you look at it, it shows just how good and intelligent a chap he actually is. In 2008, he was then recognized as a subspecialist in reproductive medicine and surgery by ASHRAE and by the European Board and College of Obstetrics and Gynecology. He then went on to complete his PhD in 2012, with his thesis being entitled The Optimization of the Follicular Phase in GnRH antagonist cycles, and became a professor in the Free Brussels University in the same year. Prof. Blockeel has worked in the field of fertility for 20 years. I know that surprises you considering how young he looks, with an interest primarily in reproductive endocrinology. He's been published very well with more than 175 papers in peer-reviewed journals and lectured at numerous international meetings. Again, I'm delighted he has taken this chance to join us, and thanks once again to Ferring for getting him to speak to us. Over to you, Prof. Blockeel.
Dr. Pravin, you were exaggerating a bit with my age, but anyway, I will accept your compliment. Thank you so much for these nice introductory words. And obviously, if you state that that Brussels is one of the most beautiful capitals in Europe, then of course you are cordially invited in Brussels and also in our center, because Also words to gratitude towards the people of Ferring who are making this event possible, and who are also organizing those so-called clinical observation programs in our unit during 2 days, 1 day and a half, 2 days time. We are sharing our knowledge. We are having discussions. We do a tour of our center and so on to see what is going on. We give some scientific lectures as well, and most of the time it is really appreciated by the delegates. So also on that occasion, you are more than welcome. Then I will share my screen now, which means that we can start with the actual presentation, because I was asked to talk about the potential mechanisms of benefit of HCG-driven LH activity. So first of all, let us start with the normal and natural cycle, because we all know that the role of LH activity is more or less situated in the mid-cycle. Around day 13, day 14 of the cycle, we see the extreme elevation of LH prior to the ovulation. But what I want to state with this is that it is not only FSH and LH as the two hormones that are secreted by the anterior pituitary gland, but also HCG. Because did you know that in around 30% of the cases, LH activity might also derive from HCG in our natural cycle? And this is, of course, important to know, because we do know very well that LH is stimulated, or let's say will be accepted by the LH receptors, but also HCG. And actually, the major difference, which you which you are very well aware of, is that the initial half-life time is around 5 to 6 times higher of HCG as compared with LH. And this, of course, results in different effects. What is the translation into the clinic? Is that important? Do we have different therapeutic options for LH activity? And the answer is...
Sorry, Professor Blockeel, I think your slides is not showing. There's no slides from the beginning. Yeah.
So I'm not sharing?
Yeah, not at all. There's no slides.
Not yet, Prof. The slides haven't been shared. I thought it was just the introduction as well.
Oh, sorry.
Okay, lovely. We can see it now.
Okay.
Yep.
So I just wanted to show so the differences in, then I have to go back a little bit. So HCG that is present in, do you see it now? Yeah. Now it's okay. All right. Sorry for this.
Yes, we see it.
30% of the follicular stage LH activity may derive from HCG in the natural cycle. And this is, of course, important for us to know. Now, we wanted to translate this into clinical practice, into the studies that have been done with regard to ovarian stimulation. What are the therapeutic options for LH activity? So let us start with the studies that have added recombinant LH to the ovarian stimulation. And we have a whole roadmap, if I may say so, of different very well and nicely designed randomized trials that have compared FSH on one hand, and then FSH with the addition of recombinant LH on the other hand. So let us have a look at the MARS trial, at the Vuong trial from Dr. Lan in Vietnam, at the PERSIST trial, and then last but not least, the Peter Humayden SPART trial in poor responder patients. So the MARS trial was that trial in more than 400 patients in the long agonist protocol who compared recombinant FSH versus recombinant FSH with the addition of recombinant LH from day 6 of the stimulation onwards. Primary endpoint was the number of oocytes. The second study, a bit smaller study, 240 patients, was actually the comparison of more or less the same thing, but in an antagonist protocol with live birth rate as primary endpoint. And then the next study was the so-called PERSIST trial, again, long agonist protocol, 200 subjects, so recombinant FSH plus recombinant LH from day 1 versus recombinant FSH plus recombinant LH from day 6 of the stimulation, with the number of oocytes as primary endpoint. And then the low responder study, 939 patients were randomized into that study, long agonist protocol, rec LH and rec FSH versus rec FSH only from day 1 of the stimulation. So let us have a look into the results of these large, nicely randomized controlled studies. And actually, there was no difference at the end of the day in terms of primary endpoints when comparing both compounds. Number of oocytes in the first study, no differences in live birth rate in the second study. In the PERSIST trial, very nice trial, we did not see any differences in number of oocytes. And then in the last study, the number of oocytes was significantly higher. Of course, we are talking about low responder patients here. This was significantly higher in rec FSH only as compared with the addition of recombinant LH. So if recombinant LH addition did not show any difference, what about the evidence on HP-HMG? And you know that HP-HMG is already on the market since more than 20 years now. We have quite some experience with this compound. And of course, the difference between ATG and LH lies in this carboxy terminal peptide that is present in ATG and not in LH. So they're very much alike, except for that carboxy terminal peptide, the CTP extension, so-called, that is important for the longer half-life time. And what kind of preparations do we have? For LH, we have recombinant and urinary and endogenous LH, of course. And then we have ATG, recombinant and urinary ATG. And as you can see, the half-life times of this ATG is significantly longer. We talk about 3 to 6 times longer as compared with LH. So again, translating this into clinical practice, what do we have today? Well, we have some studies. We have actually a lot of evidence since 2003, so more than 20 years of evidence with this HP-HMG molecule that is combining FSH with HCG. What studies do we have or what are we going to look into detail? We're going to the EISG study, the MERIT trial, then the Ernesto Bosch trial, and then the MSART and the MSART HR study. So first of all, this European and Israeli study that was comparing 350, 360 patients in each group, comparing HP-HMG 225 versus recombinant FSH 225 in a long agonist protocol setting. Primary endpoint was ongoing pregnancy. Then we have the well-known MERIT study. And I'm proud that our center participated in the recruitment of the patients. Also, again, 700 patients randomized in the long agonist protocol, comparing HP-HMG versus recombinant FSH. Then we go to the first antagonist study, 2008, comparing HP with recombinant FSH. Ernesto Bosch from Valencia in Spain did that study, to go to the 2012 study of the MSART. And it was Professor De Vroey, if I can call him my scientific father, who was the first author of this paper comparing HP-HMG versus rec FSH in an antagonist protocol. Single embryo transfer, day 5, very straightforward protocol. And then we have probably, if I may say so, the most interesting study, because we are going to elaborate on that study a bit later tonight. The high responder megaset study. So the megaset HR study, a lot of patients, 600 high responders were included in the antagonist protocol, comparing the two compounds. And what were the results? Well, with regards to the primary endpoint, which was ongoing pregnancy rates in all of the studies, we only observed a non-significant higher pregnancy rate in the HP-HMG arm as compared to recombinant FSH. So statistically spoken, there was a comparable number of pregnancies in both arms of the study. But you always see this non-significant higher pregnancy rate in HP-HMG versus recombinant FSH. What about number of oocytes? Well, if we compare, and you know that, of course, if we compare HP-HMG with REC-FSH, we will always observe a lower oocyte yield as compared with REC-FSH. And I would like to have a look at especially the megaset HR study, where we see quite a striking difference in high responders of 7 oocytes less in the HP-HMG versus recombinant FSH. But we are coming to that study more into detail a bit later. What about live birth rates? They were comparable and similar in both arms of the study for all different studies in long agonist and in antagonist protocols. So interesting findings there. Let us have a look into detail about what these studies are dealing with. So the first study I told you is the 2002 EISG study, long agonist protocol, and comparison to of HP-HMG versus recombinant FSH. So, of course, there were actually a lot of secondary outcome measures as well, such as the safety, the number of follicles, the days of stimulation, and so forth. So here we see the design of the study, in which patients were prescribed agonist protocol, and then in group A, HP-HMG, and in group B, recombinant FSH. The first 225 dose was given, and there was an adjustment possible from day 6 of the ovarian stimulation onwards. 1 to 3 embryos were transferred. You know, we are talking about 2003. So this is why we are not yet to the blastocyst stage and not yet to the single embryo transfer stage. But anyway, IVF or ICSI was performed. And the results were nice, similar, well, not significantly higher pregnancy rates in terms of ongoing pregnancy for the HCG as compared to recombinant FSH. But I would like to draw your attention, ladies and gentlemen, to this maybe small but important detail. In the study, as I told you, IVF and ICSI, both strategies were done, and there was a significant better outcome in the HP-HMG group in the IVF arm, and it was not statistically different in the ICSI arm. So, of course, there were a lot of speculations on why this would be. Is it because ICSI was quite new at that time? Is it because we are not removing the granulosa cells that are present around the oocytes that might have an impact because of the HCG that is around? We don't know. But anyway, this study was actually the well, let's say one of the major issue or the major drivers to build the MERIT study in IVF only. So the MERIT study was IVF only study and looked at the comparison in a long agonist protocol comparing HP-HMG versus recombinant FSH with a dose, again, of 225 that could be adjusted after day 6 of the ovarian stimulation. So a very similar protocol as the first EISG study conducted in European and Israeli countries. And here we see the global study, the MERIT trial, more than 700 patients included. And again, the pregnancy rates were quite, well, similar. This is a not statistically significantly different observation between HP and HP-HMG versus REC-FSH, but I think that a 5% difference might be of clinical relevance. I would like to draw your attention to the secondary outcome measures of this MERIT study, especially in terms of number of oocytes. Again, lower number of oocytes. We had 2 oocytes less in HP-HMG, but have a look at the number of top quality embryos per oocyte retrieved. We see that this was statistically significantly higher in the HP-HMG group versus REC-FSH. So for less oocytes, you have a similar or even higher number of top quality embryos. And then we look at live birth rates and we look at miscarriage rates. And you see again that there was a non-significant lower miscarriage rate of 6% less pregnancy loss in HP-HMG versus recombinant FSH. But I would like to keep this in your mind until a couple of minutes later with the MSART study. Let's go to the first antagonist paper. First antagonist study comparing REC-FSH and HP-HMG. There, we did not observe any differences in implantation rate, clinical pregnancy rate, ongoing pregnancy rate, nor pregnancy loss. But again, fewer oocytes in the HP-HMG versus REC-FSH. And there was a difference of around 3 oocytes less in HP-HMG. And then we come to the big MSART study. 2012 was the publication. HP-HMG versus recombinant FSH beta, randomized, nicely designed study in which the patients were referred to HP-HMG in group A or in recombinant FSH beta in group B, started with 150 units and then could adjust the dose by 75 international units with a minimum of 4 days on that same dose from day 6 of the stimulation onwards. 1 embryo was transferred at the blastocyst stage on day 5 of the embryonic development, and progesterone, of course, was foreseen in the luteal phase. Pregnancy results, so the primary endpoint was the ongoing pregnancy rate, was very similar, with 3% difference in favor of HP-HMG, but that was not significant for all evaluations between HP-HMG and recombinant FSH. So interesting findings. And then we look at the frozen embryo transfers and cumulative outcomes, consecutive frozen embryo transfers, and there also the cumulative live birth rates, ongoing pregnancy rates were exactly the same in both arms of the study. Again, an interesting finding of this MSART trial was the patients with high AMH. The patients with high AMH, so the upper quartile patients, well, there it was quite obvious to see that the live birth rates were quite significantly higher. Again, sorry, ladies and gentlemen, this study was not powered to do such a sub-analysis. We should do, of course, another study, but the live birth rates were significantly higher in this group of patients with high AMH. And this is, of course, extremely important because there was also lower rates of OHSS, lower need for safety interventions in the HP-HMG versus recombinant FSH group, probably because of less follicles and less oocytes also. So if it is true that there is less oocytes, if it is true that there is less chance of OHSS, and if the live birth rates are higher, talking about patients in the higher AMH strata, that, of course, brought us to the next study, namely the MSART HR. So we are going to talk about that in a couple of minutes. But before that, I would like to look at the data. If there is a comparison between HP-HMG on one hand and then recombinant FSH and recombinant LH on the other hand. And the answer is yes and no. The answer is yes, of course. We do have two studies. The Pacchiarotti study and the Kirschenbaum study, but again, smaller studies that are comparing HP-HMG versus REC-FSH plus LH. And we see a lower number of oocytes in the HP-HMG group in both studies, but at the level of the pregnancy rates, we did not observe any difference. Although you can see in the Kirschenbaum study that 29 versus 15 is quite a difference, but again, in such a small cohort of 53 patients, impossible, of course, to draw any conclusions. So this is the evidence that is available. Well, there is a couple of studies more, but these are the largest studies that are available comparing HP-HMG with REC-FSH plus recombinant LH. If we are convinced to use HCG-driven LH activity, or if we want to use it, the compounds, when should we start it? Is it at day 1, at day 6, maybe at the end of the ovarian stimulation? Well, we have the study because we remember the MSART trial, in which the comparison was made between HP-HMG versus recombinant FSH, so HP-HMG, HCG from the beginning of the ovarian stimulation onwards. And it was obvious that the levels of HCG that were measured during the stimulation played a role. They were, ladies and gentlemen, positively correlated with ongoing pregnancy. So HCG was measured, and of course we are talking about very low levels of HCG during ovarian stimulation, but still in the higher percentiles of the HCG that was measured on day 6, ongoing pregnancy rates were also higher. So it is important to start from the beginning of the ovarian stimulation with HCG addition. This, on the right-hand side, is a very nice study from Denmark, the so-called Thyssen paper. And what did she do? Well, she said, okay, let us start in a long agonist protocol with in the light blue line with 150 units of recombinant FSH. And then we add small doses of HCG, 50 units or 100 units or 150 units of HCG in the ovarian stimulation. And what did she observe? Well, of course, HCG was measured during a couple of days during the stimulation. We saw increasing levels of HCG, but she also observed increasing embryo quality in the higher dosage of HCG, 150 units, as compared with the lower and with the no addition of HCG. So again, striking results there, very interesting study. Johan Smits and Juan Garcia Arce, they stated it as such. They said, well, if we look at the MSART trial, then we see that regardless of the levels of LH on day 6 of the ovarian stimulation, it is the levels of HCG that will play a role in terms of outcomes. So you can see that increasing live birth rates are achieved with increasing levels of HCG during ovarian stimulation. Very interesting graph that you can see here. So higher levels of LH, more stable, but higher levels of HCG, higher number of live birth rates. Now let us come to the high responders. I was just telling you about this subgroup of megaset patients who had, well, a better outcome. Well, this was, of course, the next study, the megaset HR high responder study that was published in Fertility Sterility by Dr. Witz in 2020 or 21, if I'm not mistaken, where they compared HPMG versus recombinant FSH in high responders. And yes, we are talking about high responders because serum AMH levels needed to be above 5.0 nanogram per ml. And of course, patients were excluded with low AFC antral follicle count of less than 10 for both ovaries. Ladies and gentlemen, this is a multi-center study that was conducted in the United States only. So you can see here that an agonist trigger in an antagonist setting was used in case of 30 follicles. So we were quite shocked when we saw this study. In Belgium, in Europe, we trigger with an agonist as soon as we have, let's say, 19 follicles of 11 millimeters and more, regardless of the E2 values, because you know that the E2 values are less predictive in terms of OHSS than the number of follicles. So here, this was followed HPHMG or recombinant FSH and then triggered with HCG as soon as 3 follicles of 17 millimeters were observed. 1 blastocyst, day 5, and then the ongoing pregnancy rate was the primary endpoint. Secondary endpoints were, of course, number of oocytes, the rates of OHSS, and then the cumulative outcomes, but also miscarriage rates. What about the results of that megaset HR study? What about randomizing patients into HPHMG versus recombinant FSH in high responders? Well, 310 patients in each group. And obviously, we see that, well, a rather lower percentage, as far as I am concerned, was triggered with an agonist in both arms of the study. So all the rest of the patients were triggered with HCG prior to oocyte retrieval. And we continue with the whole group of patients. Of course, there was a couple of patients who discontinued and who did not have embryo transfer. What are the demographic characteristics of the study? Well, we are talking about patients with high AMH. So I told you more than 5, 7.8, 7.5 in both arms. The indications of infertility were similar in both arms, male factor idiopathic ovulation. So patients needed to have normal testosterone levels and so on. So we are not really talking about the real PCOS patients, but still extremely high responder patients. BMI was more than acceptable. We are in the US, 24 kgs per square meter. And then the results are here. We see that the duration of stimulation is 2 days to, well, 1.5 days longer in HPHMG. So obviously the consumption of FSH was higher in HPHMG as compared to REC FSH for this extremely different number of oocytes. Look here, 15 oocytes in HPHMG versus 22 oocytes in recombinant FSH. But the primary endpoint was the ongoing pregnancy rate per started cycle. And there was a non-significant higher ongoing pregnancy rate in HPHMG versus recombinant FSH, 5% difference. That was statistically not different, but it might be clinically relevant. But again, you remember that a couple of minutes ago, I told you about this 6% difference in the megaset patients or in merit patients and so on. Here, look at the early pregnancy loss. And again, I respect it is a secondary endpoint, but a difference of 9.5 9.5% less pregnancy losses in HP-HMG versus recombinant FSH. This is a quite striking result. This is a quite interesting result, and I really would like your input. I really would like your speculation. What could be the reason for a lower pregnancy loss, significantly lower pregnancy loss in the HP-HMG arm? Let us have a look at the number of oocytes. I told you 7 oocytes less. Oocytes, mature oocytes, fertilized oocytes, the difference is getting smaller. And blastocysts on day 5, top quality blastocysts on day 5 was not statistically significantly different anymore. So you can see we start with the difference of 7 oocytes, but at the end of the journey of the embryonic development, we observe similar findings. And this is, of course, extremely interesting. But let us go a bit further again and come back to that miscarriage rate. In the fresh cycle, there was a difference of 9.5, close to 10%. In the cumulative, which means the fresh and the frozen together, there is a difference in miscarriage rate of 11%. So you could say, well, this difference, maybe it's the endometrium that is different in the REC-FSH versus HP-HMG, and therefore we have more miscarriages. But regardless, when we take the frozen transfers into account and we look cumulative, fresh and frozen, we cannot say it's an endometrial issue anymore. So is there really something different when oocytes have been exposed to HP-HMG or to HCG-driven LH activity? Interesting to know. And of course, I am pushing Ferring a bit to do a study in which this pregnancy loss would be the primary endpoint of the study. And that, of course, could give us the definitive results. But again, striking to see, what do we do in our center as soon as patients develop miscarriages? We will switch from recombinant FSH into HP-HMG. And you know that Belgium has quite a particular situation. So we prescribe around, in the whole of Belgium, so in the 20,000 cycles that we have in Belgium, there is around 55% of HP-HMG monotherapy versus 45% of recombinant FSH. So this is quite striking to mention. What about safety? What about OHSS? What about our patients? Because we see, of course, an increased number of OHSS and, of course, preventive measures in terms of avoiding OHSS in the REC-FSH as compared to HP-HMG. Overall, an accepting and, well, more or less accepted rate of acceptable rate of OHSS in both arms, but still one case of OHSS is one case too much. And if you can see the difference here then of OHSS 10 versus 21%, this is not nice to see. All grades of OHSS were significantly higher in the REC-FSH arm as compared with HP-HMG, but also quite strikingly early OHSS much higher in the REC-FSH arm. Again, I would like to repeat that in Europe, standards to trigger with an agonist would be much more conservative as is performed in the United States. So what do we have? What do we have? We have the EISG, we have the MERIT, so the MegaSet, and now the MegaSet HR study, so showing these efficacy in terms of ongoing pregnancy rates. Very nice results after 20 years of HP-HMG on the market. But as you can imagine, I was more impressed by the miscarriage rates that are completely different in the MegaSet HR study, the MegaSet HR study in the HP-HMG arm. Let me share a case from daily clinic to end with. So, as I told you before, in Brussels especially, but also in Belgium, we use quite some HP-HMG. We, by the way, use in monotherapy in 95–98% of the cycles, and not the so-called combo treatment combining FSH with HP-HMG. But this particular patient, she is undergoing a first treatment cycle, suffering from primary infertility, normal AMH, normal antral follicle counts, and her husband was suffering from OET. Endometriosis grade 1 was diagnosed, normal BMI, and a regular cycle of 30 days. So in this case, we prescribed 150 units of HP-HMG antagonists from day 6. We use the fixed antagonist protocol. Ladies and gentlemen, we do around 5,500 cycles per year. So we work in strategies. And this is one of the reasons why we use the fixed antagonist protocol. So, and then like retrieval following the injection of a recombinant HCG. We do not have urinary HCG available to trigger the final oocyte maturation. And then, of course, single embryo transfer. So here we do an assessment, just to make you a bit comfortable with the data. So we do an assessment, endocrine monitoring on day 2 of the cycle prior to the start of the HP-HMG. And then after 6 days, so on day 6 of the stimulation, we start with the antagonist. And then the first assessment is performed after 7 days of stimulation. So on day 8 of the stimulation, on day 9 of the cycle. And then the decision is made based on the ultrasound scan to stimulate here, in this case, 2 days more before giving the trigger dose and then performing the oocyte retrieval. We generally do oocyte retrievals under local anesthesia. In this case, 1 embryo was transferred and 3 were frozen. So it is very nice that these figures are depicted in different colors. So we know very well, oh yes, green is progesterone, E2 is the red line, for example. So, and then we have our FileMaker Pro program to see that there were 6 oocytes. It was a relatively low response. 5 were mature. There were 4 fertilized. 1 blastocyst on day 5 for embryo transfer, and 3 were cryopreserved. And then, of course, there's one word that you need to learn in Dutch. In Flemish, it is zwanger. So she got pregnant. So this is a case how we use it. Afterwards, she came back to do the frozen transfer in a completely natural cycle. In this case, she was triggered with her ovulation, and then a frozen embryo transfer was foreseen. We usually, I see that this is missing here. We usually do a blood sample on the day of the frozen embryo transfer. In case in a natural cycle, the progesterone is less than 10 nanogram per ml, we will substitute with MVP or with oral dihydrogesterone. And of course, she got pregnant. Ladies and gentlemen, ovarian stimulation is always a combination of selection and apoptosis. We have more than 20 years of experience with HP-HMG, and compared with REC FSH alpha, but also beta, in normal and in high responder patients, we see, well, obviously less oocytes for a similar or even higher number of blastocysts of first quality and similar live birth rates. But again, and now I would like your input to speculate on why this early pregnancy loss would be lower with HP-HMG as compared to recombinant FSH. I would like to thank you, ladies and gentlemen, for your attention. Thank you very much.
Thank you very much, Prof. Blockeel. We will now move into the question and answer portion of our webinar tonight. Could you please type any questions you have into the Q&A chat box, and we'll get it from there. We have a couple already, Prof. Blockeel. Let me read them to you. This is from Dr. Rajesh Koradia in India. First of all, he'd like to know if there's any HP HMG preparations where LH activity is not derived from HCG. And secondly, he's asking about an alternative kind of dosing regimen where, have you ever heard about people using recombinant FSH with small doses of HCG from the beginning of the stimulation?
I should have shown it. So in 2009, in the early days, and this was actually part of my PhD, what we did is we replaced recombinant FSH at the end of the follicular phase by HCG, low doses of HCG, which was very interesting because you know that as soon as the follicles develop LH receptors, so we are talking about follicles of 10, 12 millimeters, they start expressing LH receptors. So actually, you do not need any FSH anymore. And what we did was, so after 6 to 7 days of ovarian stimulation, we stopped with the administration of FSH, and we give low doses of 200 units of HCG to the patient. So first of all, 200 units, is it available? No. So it was with the diabetes syringe that we were taking 200 units of HCG. Of course, we were afraid of premature ovulation, premature luteinization, which did not happen. And we have published that in Human Reproduction in 2009, and it gave us some very nice results. First of all, in terms of number of oocytes was similar, but secondly, in terms of cost, the cost of not prescribing FSH anymore in the last days gave us a lower consumption of around 20% of FSH, because HCG is much less costly, and this is probably why it did not get introduced, because of course the companies were not at all interested in this strategy, which was so nice, and maybe we should elaborate on that more. The question was also, what about LH from the beginning? So I showed the data of Dr. Thyssen, who said, well, it is important to start the LH or HCG-driven LH, if you wish, activity from day one of the stimulation onwards, because at that time, the follicles are developed and the impregnation of HCG could already play a role there. So important to add HCG from the beginning.
Sorry, just to clarify, Prof. Blockeel, you said you only have recombinant HCG in Belgium. So meaning when you added the small doses to your study in 2009, you were using recombinant HCG?
No. So the urinary HCG has been taken from the market in 2020, if I recall well. So at that time, there was urinary HCG available.
Okay.
Yeah, sorry.
We'll move on to the next question. It's from Dr. Aditi Trivedi from India. Dr. Aditi asks, is there any role for HP-AMG in dual stimulation cycles? Does it help in getting more M2 oocytes and better embryo quality? This may have been answered a little bit during the talk as well.
Exactly. So first of all, we did not elaborate on duo stimulations. Because I've always been a bit puzzled by this strategy of dual stimulation. If the nice embryo, if the nice oocyte is coming from the first stimulation, then it is a pity to have done the second stimulation. But anyway, if you are doing PGT, I can still respect that you only want once the cost of the PGT. But anyway, in dual stimulation, or in single stimulation, it is obvious that with HP-HMG, you will have a lower oocyte count as compared with recombinant FSH. That will probably not play a role. But again, it is not only the number of oocytes that count, but let's look a bit further in terms of embryo quality. And I know that the study probably has not been done. As far as I'm aware, the study has not been done with HP-HMG, but I think that in terms of quality of the blastocysts, we are on the right track with HP-HMG. Yes.
Okay, moving on to the next question. We have an interesting question here from Dr. Adila Ahmad. She wondered, you asked us to postulate about the higher pregnancy losses. She wondered, could the higher pregnancy loss due to the cases be triggered with a GnRH agonist, as there were higher numbers receiving a GnRH agonist trigger in the REC-FSH group as compared to the HP-HMG group? So did all patients in both groups receive the same luteal support medication as well? Those were the two parts of her question.
Very, very interesting questions. A sub-analysis was performed in the fresh embryo transfer group and in the GnRH agonist triggered frozen embryo transfer group. And there it was not, well, the difference was again there. So in both groups. So regardless of the trigger used, regardless of the strategy, fresh versus frozen used, there was a significantly higher number of miscarriages in recombinant FSH versus HP-HMG? That's a very good question, but well, I cannot say it is that because the sub-analysis has been done. The luteal phase support then in the two groups, well, it is obvious that when the HCG when the patients were triggered with HCG, then we are talking about the normal luteal phase support. If the patients were triggered with an agonist, then per definition, a freeze-all strategy was performed. So there was no rescue of the luteal phase in the agonist trigger patients.
Thank you, Prof. The next question comes from Kitawi Ratana Watanasin. Could you share any experience or data about HP-HMG versus REC-LH in progesterone priming only protocols, PPOS protocols?
Yes, there is a couple of studies that have been done with HP-HMG. Honestly, I am not aware of studies in PPOS with recombinant LH, but I assume that it would be the same. First of all, in HP-HMG PPOS, it works well. Again, we have not experienced with recombinant LH plus FSH than in PPOS, but looking at the endocrine profile, looking at the basic physiology, I would not assume there would be a difference there. So I would really say, let's go for it and do HP-HMG or other products in the PPOS protocol. Sure.
Thank you, Prof. The next question comes from Dr. Avantika Vase. This question is interesting because I was thinking the same thing. She says, please share your experience regarding the combination of recombinant FSH and HP-HMG in poor responders. Because I read Dr. Maria Cruz's paper in 2020 as well, where she pointed out that HP-HMG had a lot of benefits for the younger age group patients, those below 38. But what about the older patients? What about those who are poor responders?
First of all, I don't like the word poor responders. They are not poor, but they are low responders. I'm trying my best to tell about the low responder patients, but low responders are low responders, Dr. Pravin. So we have tried so much in this so difficult group of patients that it that it has become pathetic. I would say. The difference, the study, HP-HMG, for example, versus recombinant FSH plus HP-HMG has not yet been done. You know, the so-called, anyway, the first author was Dr. Drakopoulos together with Dr. Polidos. We did the COMPORT study. The COMPORT study was the study that compared corifolitropin alpha followed by HP-HMG versus recombinant FSH 300 alone. So there you could say, well, this is more or less a combi, but what was seen that the number of pregnancies were exactly the same in both arms, but there were more frozen embryos in the corifolitropin alpha followed by HP-HMG arm in that arm. So more supernumerary embryos. Again, it would be nice to repeat the study and to say, well, let us have a look into low responder patients, group A, REC-FSH alone, and rec-FSH in combination with HP-HMG. The study still needs to be done.
Sorry, just to add on to that, there is a question about this as well, because we do understand and we do realize that HPMG gives us a lower oocyte yield. So in a low responder patient, it would be a little bit more risky to just use a monotherapy protocol. On that note, I wanted to ask you, Prof. Blockeel, you said in Belgium they do about 55% monotherapy, HP-HMG, but you yourself told me that your center is significantly higher, correct?
No. So we use also around 55 to maybe 60% of HP-HMG, but we use monotherapy. Yeah. We use monotherapy with HP-HMG or with recombinant FSH in 98% of the cycles. In Belgium, we have a reimbursement and we need to stick to a certain forfait. So we are prescribing, first of all, a monotherapy because of financial reasons, but secondly, because of the extreme lack of evidence. Because you could say, well, yes, it is a bit tricky to prescribe only monotherapy in low responder patients. I respect that, dear colleague, but where is the evidence that a combo treatment, that the combination of two gonadotrophins will yield higher pregnancy rates? We know very well the study of Berkanoglu from Turkey, describing a nicely randomized study, 300 versus 450 versus 600 units of FSH. What was the difference at the end of the day? Nothing. Similar outcomes, similar number of oocytes. So you can exploit your ovarian reserve as you wish, but if there is no reserve, you can exploit what you wish, but you will have a similar number of oocytes. So hammering our patients with too much FSH, regardless of which kind of FSH you choose, I doubt it. And by the way, why has the study never been done? Monotherapy versus combined therapy. Where are the studies? And I know and I respect that in 60 to 70% in the world, especially the US and also Southeast Asia and so on, the combined FSH, HP, HMG therapy is prescribed. But where are the studies?
I can tell you from personal experience, I am one of those you are alluding to, who did jump on the horse really when we said, okay, when monotherapy fails for a second cycle in a low responder, we'll add recombinant FSH with HP-HMG or with other HMGs. And actually what we found is, honestly, the levels were almost the same. We haven't published any data on it, but I'm sure we will in the near future. And I do have to agree with you that as of now, with the limited numbers we have had, the data has been the same. Okay, let me just check if there are any more questions.
The question, I see that the questions more or less refer to the same. So the combination of two products, how can we enhance the number of oocytes? But again, why do we need more oocytes if at the end of the day the number of blastocysts will be the same? So of course I respect that, and I also love oocytes. I like oocytes a lot, as long as it is in safe circumstances. But given the lack of evidence, we still do not prescribe the combi therapy.
I have one question here from Dr. Rajesh that I think we didn't answer earlier. He wanted to know, is there any HP-HMG preparations where the LH activity is not derived from HCG?
Where the LH activity is not derived, well, there is of course preparations of LH, and so recombinant LH, not derived from ATG. But he is asking for any HMG.
Yeah, I don't think there is.
HMG not derived from ATG. The answer is no. Huh?
Yeah.
We have you have different products coming from ATG, coming from the pituitary gland, from the menopausal women, coming from the placental ATG, and of course people want to find differences there, but there is no real difference. But otherwise, I'm not aware of any preparations where LH activity is not derived from ATG.
Dr. Maria Cruz's paper actually said that HCG derived from a menopausal origin was superior to the others when she broke down the data. Has there been any other studies to sort of support that assertion?
No, I'm not aware of a study that is comparing the both products, the pituitary HCG, I would say, versus the placental HCG. Of course, the acidity is a bit different, and people might play around there, but I'm not aware of any study.
I think we're just about done. We're reaching 9 o'clock local time. I would like to take this opportunity once again to thank Prof. Blockeel for your time. It was a very insightful lecture. As you said, there are a lot of common misconceptions that are addressed in Southeast Asia, in America, I will admit that. And it's good for us to see a differing viewpoint where we can always change our management and try different things. Thank you very much once again, Prof. Blockeel. Thank you very much once again to Ferring for organizing this. I definitely will take you up on your offer and visit you someday in Brussels to see your center as well. For a reminder for all the participants, thank you so much for attending, especially to the people from Thailand, from Vietnam, from Indonesia, from India. Please don't forget to join us for our MSART Congress. The information is on the screen now. And I bid you all a good night, good evening, and good afternoon, wherever you are in the world. We at MSART are very happy that you joined us. Thank you, Prof. Blockeel.
Thank you so much, dear doctor. Bye-bye to everybody. Bye-bye. Thank you.